everyone, I am doing tonight's live on the ACL, which is the anterior cruciate ligament in the front of your knee. We'll get ready in a few moments. We'll just wait for a few people to kind of start. We hope everyone had a lovely Jubilee Bank Holiday weekend. Fabulous. So I'll wait for a few more moments and then I'll get started. Okay, fabulous. So I will get started, and if people join in or have any questions afterwards, then we are always more than happy to answer them. So as many of my clients know, I specifically did my dissertation at university on the ACL, and more specifically the likelihood of female athletes sustaining injuries, which is why it's something that I focus on quite a lot, and especially on the knee, as a result of my interest that I had at university, and then therefore taking me on to do my dissertation on it. So obviously in terms of the knee, Joni and Nat have both previously gone over it a little bit in terms of anatomy and its physiology. So if you want any more information about the knee itself, then please refer back on to their information. So in terms of the ACL, what one of its main jobs is to do is to stop the femur sliding over the tibia and the fibula. So it will stop this kind of movement happening. So in terms of when the injury presents itself more, it is more common as an injury in female athletes as it is in male athletes. As you can see from ratios that we've put on the thing, it's a very big gap. So the ratio is between 2 to 8 times more likely for a female to sustain the injury and in comparison to a man. And of that, in terms of the normal mechanism of injury, 80% are due to non-contact. So that means someone hasn't even knocked into someone, their knee has just literally gone from either planting their foot incorrectly, changing direction, or ligament laxity, which is something that's very, very common in female athletes and which can cause them injuries. So generally speaking, when we're looking at the ACL, we are looking at anatomy and stuff like that, and we're looking at gender differences. Females generally are seen as the weaker sex in comparison to males, and this is more prominent and more seen in ligament laxity. So women generally already have more lax ligaments in comparison to men. However, when women are on their menstrual cycle, it has a greater risk of injury. So what happens is the estrogen and proestrogen, they cause more laxity in the ligaments, and they generally tend to be higher during the menstrual cycle when a woman is on her period. So unfortunately, when it comes to training and training specifically around that area, as we said in previous lives, which I did on the menstrual cycle, I stated that it's really, really important at that point you are training more and focusing more on strength than you are doing loading and change direction and acceleration, deceleration. When you're working on strengthening, you are generally working on that area. You're doing more isometric, concentric, eccentric movements. You're not particularly working in a movement plane that can put you more sustainable to an injury, specifically causing the femur to slide over the tibia and the fibula. So it's something that's been researched quite a lot, and it's one of the main reasons as to why I did decide to do it for my dissertation. There are numerous risk factors, such as neuromuscular control, obviously non-contact mechanism of injuries, gender differences, and then just normal strength. But there are also other things that we tend to look at as therapists, such as your Q angle, which is more common to be wider in females than males. We look at knee, varus and valgus, which is the positioning of your knees. So this would be a normal positioning, and then this would be varus knee, valgus knees, and then this would be varus knees when they're pointing outwards. So each one of them will also change your Q angle and invertebly. And then we'll also look at ground reaction force, which is the peak contact when you are landing. And then we will also look at your knee flexion when landing and stuff like that as well. So generally with the non-contact mechanism of injury, it normally happens during landing, when someone's, say, gone for a jump, gone for a header, and then they've landed and they've had one of those has gone too far and it's caused a lot of stress onto the area. Unfortunately, it's either torn it, or in worst cases, it has then unfortunately ruptured the ACL. So basically, when we're looking at Q angles, what that does is it's just telling you more about the positioning of certain things. So when we're looking at the Q angle itself, when there are greater pulling forces, what happens is the patella is being pulled more by the quadriceps tendons, and what that then does is put more pressure onto the ACL as well. So what we don't want is too much tension going to the left, going to the right, or going too far forward, because then what that's doing is causing the tendons to pull, which is going to pull the patella up, which is then going to greater expose the ACL and subsequently result in that causing the injury. So in terms of when injuries normally happen, your muscles and your tendons will intervene first. If they can't and they are stressed out fully, normally the ligament is the last contractile tissue that will stop the movement pattern kind of happening. So what you normally want when it happens is you want your femur to kind of slide, and you want your quadriceps and your quadriceps tendons to pull the knee back, stopping it from going too far forward. And unfortunately, sometimes it doesn't happen, and what happens is it will just slide forward, and the ligament's contractile strength is not as strong as tendons and muscles, as explained before. So then that will cause the injury, and that will cause the rupture. So when presenting and looking at patients in clinic, what we will do is the anterior draw test. So we will hold onto the back of their leg, placing our thumbs just in front on the knee, either side underneath the patella, and then we will gradually pull the knee towards us. And if in that movement we have a lot of laxity, or as we say, movement, and you can physically see the condyles and you can see the gaps in between, then that's how we know that unfortunately there is a rupture or some form of tear. Grading is a lot harder to do. Normally that is confirmed by MRI scans. With a rupture, you'll have so much movement, you'll be able to play around, unfortunately. So normally an indication when it's not fully torn and it's not fully ruptured is you will have some laxity, but you won't have enough that it will be allowing you to move it quite easily. So in terms of when we're looking at the injury rates and stuff like that, that happens due to non-contact. So approximately 70% of all injuries are, sorry, I'll re-say that again. So 70% of all ACL injuries are due to non-contact mechanism of injury. So 29% of them are from foot strike onto landing. 28% is due to landing with an extended knee, and about 26% is landing in hyperextension on a single leg. So as you can see, that's quite a big variation, and they're the three kind of main ones that break it down. So obviously with that, it is really, really important that we focus on each one of those small areas. So obviously foot strike is one of the most important things. It's something that we focus on a lot when we are doing gait analysis and when we're getting someone back to return to play. So if their foot strike is wrong, so this will be whether their foot is landing nice and straight, whether they're landing with eversion or whether they're landing with inversion. And obviously what we don't want is those different positions to cause more pressure. So when specifically looking at landing, what I did for my dissertation and what I do in clinic is I will get my patient to just take a step off the box, so a plyo box, normally about 30 centimetres in height, get them to jump off and land. And what I'll do is just look at their normal way of landing. So what I will be looking at, key points, is where their knees are positioned, where their hips are positioned, looking at their feet, and then obviously I'll be listening for sounds. As we don't have a force plate, we can't technically look at their ground reaction force. However, the impact in which they land on the mats we can hear quite well. So when someone lands, they've got a really big smack. That means there's a lot of force going through and it's not being absorbed. That is a full impact of the toes and the heels together at the same time. Whereas people who generally land heel to toe or toe to heel, it sounds less and it doesn't sound as impactful, so it's nice and controlled, which then means they've got less impact with that. In terms of landing with flexion, what we don't want is the knees going too far over the foot. So that's why we will look a lot on flexion. So with that, as you can see, flexion is this kind of movement. So opening and closing. So flexion is when you're kind of here. So when you're landing, this is normal 90 degrees. So what we want is either 90 degrees or anything to about 75. Anything 45 degrees and more, what will happen is the knee will be over the toe of the foot. So what happens then is that's creating a tighter strain and pressure on the quadriceps tendons and the patellar tendons at the front, which inversely then is putting more pressure onto the ACL. So what we want to do is then educate and change that and then reduce all of that tension and making sure that they're landing with enough absorption and enough flexion that they are not stressing it out too much. And then in terms of obviously with people landing with their knee straight, again, we just make sure that they're bending their knee when they're landing, so they have some form of flexion. Unfortunately, with people who do land generally with hyperextension, normally they have had some form of contact in the air, not necessarily when they're landing, but in the air. They might have had some contact where they might have been pushed, and then when they've gone to land, their legs just kind of stay straight and it's kind of buckled backwards. So for us, it's really, really important that we try to minimise that as much as we can, but unfortunately sometimes accidents do happen, so we can't always necessarily prevent that, but what we can do is make sure that we strengthen everything around it, trying to reduce it as much as what we can. And then obviously single leg landing generally will cause a lot more ground reaction force, Q angle, knee varus, knee valgus. So my last live that I did was on foot positioning. So that speaks a little bit about varus and valgus in terms of the knees and how that can affect different things and how that can then inversely affect your Q angle. So again, it will kind of have the same effect on the ACL. It's really important that your knees are landing nice and straight. Too much going out, too much varus, too much stress on the lateral tendon and the lateral quadricep muscles. If you're landing with too much valgus, then again, same thing on the medial aspect. So what we don't want is too much going in and too much going out, because then what will happen is this side will be the one that will tear and then it will kind of ricochet and fall out to the other side. Same thing if you're landing that way, it will go from the lateral aspect and then it will form inwards. So what we ideally want is someone to land with nice straight knees, nice flexion, not too much hip movement, not too much force. So it's a nice heel to toe kind of contact and it's a nice strong landing. So they're kind of landing, so imagine you're taking a step off, step nice and straight, bend the knee, absorb it, stand back up again. So in that movement, you're either doing a heel to toe or a toe to heel movement, which is helping to absorb it. And then there's less ground reaction force and less force going through. Obviously, when we're looking at stuff like that, in terms of flexion, extension, ground reaction forces and varus and valgus, that comes under kinematics and kinetics, which is something that you'll tend to study in kinesiology, which we do at universities and stuff. So that normally comes in more in terms of like vertical jumping and more of the landing. So it's explaining kind of what's going on more with the body and the movement itself. So if that's something that you're interested in, we can go a little bit further into the difference between kinetics and kinematics. But the main focus is making sure that the ACL has not got too much pressure when you are landing. So when looking at studies that have been performed previously and before, they always look at different landing techniques, and they'll use jump landing, drop landings, or they'll use some form of 1-2 step landing, and then they'll look at the jump afterwards as well. So what is really, really important when you are going through this kind of process and you are looking at how you're kind of landing, it is important to look at the things that we said before, but then it's also important to make sure that you do know how to jump and you do know how to land correctly, because all these factors that we then look at are predictions of as to whether you are going to sustain an injury. Because if someone has too much knee varus, too much knee valgus, too much flexion, a really wide Q angle, and then they are on their period, then they are more sustainable to sustain a ligament injury, specifically for the ACL when doing certain sports. So it's really, really important that if you do feel that you aren't as strong in your quads and you are having different issues when you are landing and when you are jumping, then it's something that's really, really important that you should look at, as you don't want to sustain an injury. Obviously, there are other factors that we can't control, so which we call intrinsic and extrinsic factors. So ones in which we can control and ones in which we can't. So extrinsic factors are normally weather conditions, surfaces, surface types, clothing, and then levels of participation. So this is the difference between playing with people who are all at the same level, or those that are some are elite and some are quite bad. So sometimes if someone doesn't have the correct knowledge, that can then also predispose you to injury, as you might have a contact injury because you might have been in the wrong place, wrong time, sort of thing. The same thing with weather conditions. If it's quite slippery outside if you're training, or the grass is quite hard, again, all of that planting, if you're wearing boots or you're wearing molds, again, that amount of pressure and then force that's going to cause that movement is really, really important. What you want to do is make sure your body's prepared as well as it can, so your quads are as strong as they possibly can be to kind of prevent that from happening. But you also want to make sure that you are training your hamstrings at the same time. We do not want quad to hamstring ratios being 3-1. That also is a reason as to why you can sustain an ACL injury as well as quadricep injuries, because you have a lot more quad strength ratio in comparison to hamstrings. So it's really important that you focus on both, but sometimes if you are doing more sports with jumping and landing and a little bit more change of direction, it is a little bit important to make sure your quadriceps are very strong as well. So in terms of intrinsic factors, that's neuromuscular, biomechanical and physiological. So generally, with the main risks in that is obviously genetics. You can't change certain things. You are built how you're built. You grow how you grow. But also mentality is quite a big thing. So it's really, really important that you are always ready to do exercise and you are prepared, as any doubt that you may have can sometimes lead to injury, which we have previously stated before. So in terms of like what we kind of say is the 5 main kind of risk factors is hormones, genetics, cognitive function, previous injury and extrinsic factors. So when looking at each one of them individually, obviously there are different things that we look out for when we want to maintain. So what I'll do is I will link some previous case studies that I've looked at that will explain them all into a little bit more depth as to kind of what they kind of do, as we could go on for hours talking about those things individually. But they're the main things that we look out for. And obviously with looking at the likelihood of injuries and stuff, yes, it is still very common in men. We're not saying that at all. We're just saying it has a bit more of a common theme in women. In men's football, there's been loads of athletes that have had that issue. You had Michael Owen, who sustained quite a few, and then you've also had Bradley Dack from Blackburn Rovers. He tore one ACL and then went and tore the other one on his opposite leg. In female football, the most common one, well, the most new one is Chloe Kelly. Ruptured one side, went back, ruptured the other one. She's now back fully training and playing again. But with an ACL injury, normally the minimum you will be out is 6 months. And that's a minimum. That's not being back to full training, being back to full playing. It can be a year, even at the elite levels. So it's really, really important, if you ever are suspecting that you have ruptured or torn or hurt your ACL in any way, that you do get it checked out straight away. There is obviously now a lot of research stating that you don't need actual surgery to reconstruct and to have a fully intact ACL. You can technically still play, rugby, which they have got a few players that don't actually have ACLs who are still playing rugby very, very well and at an elite level. However, it does just obviously put you at a slight disadvantage in comparison to other people. In terms of what we do here, we generally tend to say you have to do rehab before you have your surgery anyway. Keep doing the rehab, see how you feel. If you're progressing on well, you're not having any issues, you're not having any setbacks, you're able to do certain things, then sometimes we're like, okay, do you still want the surgery because you're going to have a setback, or do you just want to keep kind of going through? So it will all depend and vary on what kind of the MRI results show based on how much is torn, as obviously different tears will require different things, and the same thing with certain reconstruction surgeries. It's really important to look at all kind of options, but we've had many people who have had no surgery to those that have had surgery, so there's still a lot of information and still a lot of research going into it and saying which one's kind of best. They both have their own pros and cons, but obviously you still have to do rehab regardless of which one you're kind of doing, and you've always got to do rehab before because you want to make sure you're as strong as you possibly can be before you then become immobile once you've had the surgery. So it really focuses on concentric, eccentric and isometric strength. Always the same, always the base that we always start with, and then we progress through from there. So in terms of like some of the main risk factors that we will see in sport in terms of it, it's normally poor neuromuscular control. So it means that the joint and the body is just not in focus together. So your body's saying one thing, your joint's going basically the other way. So the prime example is you're kind of stepping to change direction, and normally what happens is then you step to the side, that's fine, you step to the side, but your body's then going that way, your knees kind of stayed that way. And that force and that kind of giving motion is sometimes what causes the issue. Poor technique when jumping and landing, as we said, high impact forces, obviously when landing with really a lot of knee flexion, and the same thing, just landing and it kind of keeps sliding. So it's really important that we focus on all of those things and continue to progress through. In terms of gender differences themselves, as we've already spoken and said before, men are generally stronger than women. And in terms of rates of injury itself, so let me find this one. So in a 10-year study that I've looked at before, of 3,482 injuries, 44% of those ACL injuries that were sustained in that study were due to trauma and due to contact. However, when you did a comparison of non-contact injuries, it was 52%. So there was only a 3% difference of what was contact to non-contact in between. So yes, we are still saying that non-contact method of injury is greater. However, you still can have it a lot more severe in terms of contact injuries. So normally with a contact injury, it generally tends to be more severe in terms of pain and in terms of what it will kind of present with in comparison to a non-contact mechanism of injury. Because generally if you have contact, direct trauma, you will likely rupture it more than anything else. It doesn't always happen, and it's not always hearsay, it's kind of what happens. However, in terms of the injuries themselves, it normally does happen due to non-contact, just based on all those factors that we've listed before. Normally the ratio in terms of like injuries to the knee and stuff like that is normally 2-to-1 to females in comparison to men. And this can be due to a number different of factors. So generally with women, we tend to do a lot more pivoting, a lot more kind of change of direction, and obviously we have different sizes and different reductions and different things. So because men are generally stronger in the quadriceps, they generally have more stronger ligaments, they have bigger joint sizes in comparison to us, and obviously we generally have large Q angles. So in terms of when you're looking at sports in comparison to when they kind of get injured, in basketball and netball, it's seen more as a non-contact mechanism of injury in comparison to football, when it seems to be a bit more of a contact one, or it's after a contact force. But in terms of like all of what literature is saying, it's always saying it's because there's been a significant amount of stress prior on the quad and the quadriceps tendon, and then the ACL is gone afterwards. As like I said, the ACL is kind of the last chain of support. It's the same thing for all ligaments in the body. All of your tendons and structures will support everything, and it will try to stop that movement and stop the joint coming out of place. So then what happens once they've all kind of failed and they've not stepped in, then the ligament is the last thing to kind of support it and hold it in place. And if there is a significant amount of force, then 9 times out of 10 it will unfortunately tear or have some form of rupture. So when we are looking at the biomechanics, we all really want to focus on pivoting, we want to focus on jumping, and we want to focus on landing, which will then break down obviously the varus valgus, ground reaction forces, and then heel to toe strides. Obviously, if you're also then looking at the differences between landing on one leg and landing bilaterally, the exposure rate is greater if you're landing on a single leg in comparison to a bilateral landing. And that's obviously because there will be a lot more force going through the one leg. So it's got a 15% greater incident rate if it's non-contact landing on one leg to non-contact landing on two. So normally what will happen with it being the one leg landing, you'll have a far greater Q angle. So normally anything between 15 to 17 degrees is normally seen to be quite a large Q angle. So if you imagine this is the leg, and then you'll have your greatest trochanter and the head of your femur, and then you'll have your ASIS here, and then you'll have your knee. So the Q angle is the degrees and the movement of which this all kind of moves together. So what we have and we expect is just normal, about 15 degrees. Anything wider and it starts to go like that, then that's when we have a larger Q angle. What that will then do invertebly is then create either a knee varus or knee valgus movement. 9 times out of 10 it will cause a valgus movement, and then that will then cause the foot to kind of roll out there. So what we want to do is reduce that as much as we can by getting your adductors and your glutes working with your hip flexors and your quadriceps, so they're all working together and it's nice and strong and it's nice and supported. Because if you're in this position, that's not comfortable, and obviously that for women we're generally going to be wider because we have to bear children. Let me just have a quick drink. And obviously, anatomically, that's natural to have an acute angle like that. If someone's bones are kind of like this and very straight, then they're not going to have much gap in between their hip bones and stuff like that, so it'll be very uncomfortable, and then their knees will be very close together. So it is natural to have a Q angle. There's nothing wrong with having a Q angle, you just don't want one that's a lot wider than 17 degrees. In terms of when landing, what you kind of want, as I said before, is between 15 to 45 degrees of knee flexion. So it's not saying 15 like this and 45 like that. It's saying in this kind of range. So imagine you're at 90 degrees, it's then from the 90 degrees underneath. So then it will be the 45 to there, 15 to kind of there. So it will depend on that kind of range. So it won't be from your initial standing, because then if you're saying 15 to 40 degrees and it's that much, then that's not much flexion at all. It's coming from the 90 degrees, then it's bringing it down to lower. So anything between 45 to 15 degrees from there is fine. Anything more than the 45 degrees is when you're more susceptible to an injury, and also anything less than that 15 degrees, again, if you're then going above, then again there's so much force, so it will be kind of pushing your femur this way down, so again you'll be putting strain onto it. And then obviously looking at knee varus and valgus, same sort of thing. So you want between 5 degrees either side, give or take. Anything kind of more than that, again, sustained due to more of an injury. That will generally come from your Q angle. So ideally we want neutral, so we want 0, varus and valgus. However, you can have a small percentage, 5% at 5 degrees either way, as naturally the body sometimes does force the knees out or force them in, so that's fine, but nothing too excessive. So like I said, anything above 15 degrees we'd want to correct and rule out. And then in terms of ground reaction force, it depends and it will vary based on your sport, your shoes, and the surface in which you're playing on. So as we said, if you're doing training inside, we'll kind of hear for how much impact you've kind of got. When outside, when it's kind of soft as terrain, then it reduces the risk of injury because the floor will be a lot more absorbent for you. So generally basketball players will suffer sometimes more injuries as a result because of how great their landing is in comparison to the solid floor. So their floors are slightly springy, such as netball ones as well, to give you a little bit more give and take, a little bit more shock. But it's really, really important that you do look at all of those factors. So what I will do is I will put up some of the figures, and I will also attach some of the literature reviews and case studies that I've researched and I've looked at, telling you a little bit more about the ACL. I'll put some specifically towards females, talking about a bit more about how the hormones can kind of affect it, and I'll link my previous live to it, and I'll put on some that's talking about the different gender differences between the two in sports, and then saying which sports are more likely to sustain the injuries in comparison to others. If anyone has any questions, please ask now. If not, then you can always just drop myself or Joni any questions, and we'll be more than happy to help you. So thank you to anyone that has joined in to watch. Replay will be available within the next 5 to 10 minutes, and I'll do a little blog about everything. So thank you very, very much for listening, and I hope you enjoy the rest of your evening. Bye.